Hello and welcome everyone. I am super excited to introduce the speaker for the last Women in Network seminar this year. So today we have Dina Mistry. She's a network scientist currently working in the epidemiology team at the Institute for Disease Modeling, which is a part of the Bill and Melinda Gates Foundation. She earned her PhD under the supervision of Professor Alessandro Vespignani at the Network Science Institute at Northeastern University, and her research focuses on characterizing and modeling the heterogeneity of social contact networks and mobility networks. And I'm super excited for today's talk. So Dina, it's all yours.
All right, great. Thank you, Alice, for inviting me to give this talk. I'm super excited to show you guys what I've been working on and sort of give you a sense of how network science interacts with epidemiology and how a lot of us are using it to do analysis for the current pandemic. And just a quick note, like I'm not the only one that's working on this, so I'm really presenting this work on behalf of the Institute for Disease Modeling's COVID response team. So a little bit about myself before we get into the talk. As Alice mentioned, I did my PhD at the Network Science Institute. I really have my PhD, my master's, all of my degrees basically in physics. But for the last couple of years, I've been focusing a lot of my work on what's known as complex contagions, trying to understand how things spread in complex systems like networks through the lens of physics. So my dissertation work focused on characterizing and inferring diverse human contact networks around the world and mobility networks, and then using those patterns and trying to integrate them into infectious disease models. Beyond that, I have research interests in outbreaks / pandemic science, behavioral modeling, and something that I'd like to get back to because I think it's really relevant for what's going on right now is the phenomenon of vaccine hesitancy and misinformation. And I would not be a network scientist if I didn't give you the obligatory hairball network. So on the right, it's just an old project of mine, but I thought, pretty network picture, we need to all give at least one of those for any talk. And again, something that I want to point out is that the work that I'm presenting is not just mine. It's really the effort of a lot of people. I really do think that science is a collaborative experience and the work of more than one. So these are all the people that I'm very fortunate to call my collaborators on the current work that I'm presenting. And it's not a complete list of everyone that I've worked with in the past year, but this is a lot of the folks who have contributed in some way to the projects that I'll be talking about today. So by now, I think a lot of you have probably heard about infectious disease modeling, and I probably don't need to go into all the details, but I'll just give you a brief overview of what we mean when we say infectious disease modeling, or what I mean rather. So when I talk about infectious disease modeling, I'm really talking about mechanistic models, and I'm talking about modeling how people go from different disease states throughout the course of a disease spreading in a population. So the most basic model you can think of is what's known as an SIR model, where you track people going from the health states of being susceptible to a disease to being infected, and then finally to being recovered or removed from the population who are susceptible to the disease. And this is a very simple depiction of it, where you kind of are modeling essentially people in the susceptible group getting infected by those who are in the infected or infectious group. And there's some sort of information about how people are interacting in your model, and then the infectiousness of the disease itself. So, there are different diseases that are very infectious. In some sense, COVID is one of them. And then there are other diseases where really they're not very infectious. It's very unlikely for you to get the disease if you're in contact with someone that's infected. And so in all these kinds of models, we really do take into account those different aspects. There's also, and I apparently forgot to include it, there is a rate of recovery that's involved in these models as well, right? And this is, again, a very simplistic version of an SIR model, but it's the most basic that we would think about. Oh, hey, it's a slide build, great. So beyond that, beyond the most simple SIR models, it can get a lot more complex than that, right? So for example, in some diseases, you might have something like an exposed state where someone is infected with the disease, but they're not actually able to infect people yet. And there are different types of infectious states as well. So in some cases, people can be symptomatic with infections, and so you can actually detect them very easily. You know who's sick because they're presenting symptoms. And then there are other kinds of infectious people who are asymptomatic. They show no signs of having the disease, no clinical manifestation of the disease, but they are still infectious. They're still infected, and they can transmit the disease to others. Of course, there are also multiple states that you can transition to afterwards. So in some cases, you may recover. You may also succumb to the disease, and those who have recovered can also end up becoming susceptible to the disease again if their immunity wanes. So this is just to give you a sense of the kind of complexity that gets involved in infectious disease modeling, even in the most basic of model setups. So I think something to understand about infectious disease modeling is that really the kinds of complexity that you want, the kinds of models that you want really have to do with the complexity of the question that you're asking. If we have goals of forecasting or forecasting diseases in the future, if we have goals of nowcasting, if we want to know how interventions work in different populations, these all require different types of models. So in the most simple type of modeling framework, which I would consider to be a homogeneous mixing model, essentially you're assuming things like people mix equally. There are no details on people. These are really computationally easy to do, but as you might guess, it's fairly unrealistic behavior. And for the most part, this is not the type of modeling that a lot of people would try to use to understand current outbreaks or how diseases are really spreading in realistic populations. You can go to a more intermediate step, something like a compartmental model that I've been showing before, where you have people in different groups and you can add compartments to reflect the different structures in the population. So maybe you have a group of people who are, different ages, and so therefore have different susceptibility to the diseases. You can split up your SIR model into different age groups and track people through there. It's a little bit more complex than those simple models, but it's something that's computationally pretty practical to implement. And it doesn't require you having all of the details of people involved in your population, which is useful because often that high level of detail is not really available for a lot of places in the world. And then of course, at the very high complexity, and you have things like agent-based models, which really sort of go into the realm of network science kind of models. These are extremely detailed and reflective models where you know who's in contact with who, where they live, where they go to school, where they work, where they might be interacting with other people in other spaces. Like I said, these are incredibly data intensive, but they're hard to calibrate. They're computationally expensive, but the thing is that these are actually what's needed to really assess very specific, detailed interventions like school closures or other kinds of control strategies where you're trying to understand, if we tell a certain group of the population to do something, what's the real world impact that will have? And so again, like different models are really needed for different levels of complexity. And so I feel like those of us who are in infectious disease modeling try and keep that in mind. Like, we are constantly working on different types of models because of the kinds of questions that we need to answer. Sorry. These different complex models require different kinds of data. One thing is that, data on contact patterns and the network structure can help us to understand how to control, mitigate infectious disease is spreading. On the bottom left, what I'm showing is essentially the same network, the same average degree in the network, but you can see that because of the structure of the contact patterns or the actual edges that are in the network, the disease can actually spread. So here, what I'm showing is in blue, people who are susceptible, and in that kind of red tone, a person who's infectious. And the fact that they don't have connections in the first, on the very far left, means that they can't spread their infection or whatever their contagion is to others. But as they get more and more connections, or as there's more and more connectivity in the network, you can see that they're actually able to spread whatever infection that they have. And so really, the thing is that we need to know, in order to understand how disease is spread in networks, we need to understand more than just, the things like average degree. We need to actually understand what are the complex network structures that we're thinking about and that we're working with. So here, what I'm showing you is essentially what I think of when I think about how people are connected in real world populations. So this is showing you essentially an ego network picture of two people in a family and who they're all connected to, and how an infection in one person's ego network can spread throughout the rest of the population. So for example, on the very left, you're seeing an infection in a school layer. And essentially that person, that student is infected, they can spread to the other students, and the person that they're able to spread to is the 12-year-old in the middle. And then that 12-year-old can end up getting infected and spreading it to everyone else in their network, including their family, who are kind of in the center of those figures. Once it spreads to their family, they can end up spreading it to an adult. And so that's what you're seeing on the right, is you're just seeing like an infection going from one person in a school network to essentially not just the students' network, but their parents' network as well. And so really, to understand how infectious diseases spread in real world populations, we need to understand what those contact patterns look like. We need to understand what those networks look like. So what does network science, though, bring? I mean, like I said, we want to understand what those network structures look like, but it's more than that, right? Network science can allow us to ask questions about what are the impact of things like hubs in a network. I think that this is a classic question that's already been studied in terms of network epidemiology, but really, what's the impact of having someone that has an outsized degree in a network? And what happens when that person gets infected, or if that person is the patient zero in the network in some sense. We also want to, I think network science can also allow us to ask questions about what are the impacts of clustering. So if you have a network that's highly clustered and an infection gets into one of those clusters, how easy is it for, or how, not just how easy, but, will that infection just circulate in the cluster? How easy is it for that infection to spread to other clusters? And really, what's the difference between that and just a randomly distributed network? And this, again, goes back to the question of like microstructures or things like households. How does having these groups of people change, or groups of people who are connected, like households or schools or workplaces, change the ways in which infections spread? Network science also allows us to ask, really intricate questions about contact tracing interventions. So if we know exactly who's in contact with who, then, or, at least a good representation of that, then we can ask questions like, well, so this person is infected. And now I can backtrace and ask all of their contacts. Who have you been in contact with? Do you have symptoms? Are you someone that we should be testing? Should you be quarantining yourself or isolating yourself so that you can't, so that you can prevent yourself from possibly infecting others? If you don't have a sense of who these people are in contact with, you can't ask these kinds of questions. And of course, network science approaches also allow us to ask questions about, what's the critical threshold of immunization? When you have different contact pattern structures involved, then those thresholds really do change. And so we can apply our methods from network science onto these real world populations and get a better sense of, what is those thresholds in real world populations and how does it change if our contact structures change? So with the current pandemic that I think is on everyone's minds, I kind of want to highlight some modeling priorities and really give a sense of how priorities end up changing over time. So early on in the pandemic, we were thinking a lot about, okay, how do we close high risk environments and prevent the infection from spreading from a small group of people and really going outsized. And so that has a lot to do with the closure and the reopening strategies. So where I'm situated right now, Washington State, back in early March, essentially the local authorities made a decision, I think on March 12th, that before they really started getting big numbers of cases in the state, they were just going to close down schools because we were not sure if schools were going to be an important place of transmission. But on the off chance that it was, we don't want kids getting infected, we don't want their parents getting infected, and we don't want this to spread out of control. So let's shut down schools. And of course, that has a lot of cost to it, but that was one of the early responses. And really over time with the pandemic, the kinds of priorities have changed. So we're not just thinking about what's pertinent to close or reopen now. We're also thinking about how do we trace contacts? What's the impact of test turnaround times? Who should we be testing, right? If a test takes too long to get back results, then in the meantime, if people are not staying at home, then they have the ability or possibility to transmit their infection to other people. And so these are the kinds of questions that we're starting to be asked. There's also other things like there was a lot of talk about using digital tracing apps. So having an app on your phone where you can be alerted if someone that you've been in contact with has been notified of them being infected, right? And there's been a lot of innovation around this. There's been a lot of talk about, how do we do things like having these apps, but also preserving people's privacy. Again, other questions that have come up have been things like, why are some of these groups that we're seeing at higher risk? One thing that we've noticed is that the pandemic is not affecting everyone equally. It's affecting certain groups. In the US, at least, this has meant marginalized groups from certain racial backgrounds. So people who are Hispanic or African American have been highly impacted by this disease, to the point where a lot of folks know at least one person who's been infected and or died from this disease. So it's really important for us to be asking questions about why are certain groups at risk? What is putting them at risk? What is leading them to have higher exposure? And then finally, as we now have vaccines that are promising to be really effective, the questions are going to become more along the lines of who should get vaccinated first or when resources are limited. And on the right, what I'm showing you there is just, unfortunately, a current picture of what COVID cases and deaths look like in the US. And it's pretty stark. So I think that a lot of these questions are very relevant, and this just sort of gives you an idea of why we're thinking about these things, because we really want to be able to prevent this from happening and prevent this from getting worse and just happening in the future. So my current focus of work on COVID-19 is modeling the control and mitigation of COVID in realistic contact networks. So this means that we need information about contact networks in terms of who's commonly sharing physical space. So who can I, for example, transmit to because I'm in their the same physical space as them. What are the age demographics of these populations or who I'm in contact with? The household characteristics. And so this relates to things like who's actually enrolled in school, who is employed. You know, in different places around the world, these characteristics look really different. In some places, you can have things like a 5-year-old in a workplace, and then in other places, that's not so likely, but you do have elderly folks in workplaces still. And then, of course, for each population, you really need to think about what are the other features that are interesting or necessary to model. So do you have spaces like long-term care facilities that have people who are extremely vulnerable and have, you know, maybe some interesting network properties or structures like care staff who unfortunately have to work in multiple facilities? Or is there some sort of, you know, interconnectivity that connects facilities to other more high-risk populations? And so therefore the people that are, or not high risk, but high transmission settings. So the people who are living in these facilities are unfortunately then put at risk because of these network properties or these network structures. And so I just want to point out that, you know, the data collection on these kinds of patterns have been around for a while. To me, this really starts with the 2008 Polymod study, and it's been expanded upon since then. So Polymod was a diary-based survey where they asked a lot of people in multiple countries in Europe to record who they were in contact with during the day, and then what settings they were in contact with. And since then, there have been multiple studies that use that type of instrumentation, but also things like studies using wearable sensors and time use surveys. So one of the nice things is that we do have a fair number of projects or studies out there already that kind of give us some piece of this information. So there are a fair number of projects out there that look at age mixing patterns. My PhD dissertation work was one of them. And what this gives us is, you know, a piece of the information. It tells us things like what are the average mixing patterns in different settings for different populations. So what I'm showing you on the right-hand side is just by different social settings. So like the household, school and workplace, what are the average mixing patterns? And the way you can interpret each subfigure is essentially on the x-axis is the age of an individual, an average individual, and on the y-axis is the age of their contacts, and then the color is basically telling you the frequency of interaction, or the probability of interaction between a person and all of their contacts of a given age. And so this work was done by using a lot of very detailed data from surveys and census on things like marriage rates and household composition, the number of children you would expect in families for different kinds of families, and the age gaps between household members, schoolmates, and coworkers. But of course, that's not enough, right? That doesn't actually get you the network itself. So what I've been working on recently is how to work backwards from those average age mixing patterns to generate realistic human contact networks for diverse populations around the world. So I have a Python library that I've been working on called SynthPops, which is open source, it's data driven, and what it does is essentially uses those age mixing patterns and then uses other information to infer what likely networks are for those different populations. So using those age mixing patterns, we can essentially get a sense of who's likely, like what are the likely ages of people in contact with each other. And then it uses that to actually create the networks themselves. So SynthPops sort of focuses on those key settings for disease transmission for a lot of places around the world. Essentially, households, schools, workplaces, and community spaces. It also has, we've been working on some methodology to include things like role-based connections. I'll talk about this a little bit later in the talk, but it's really important to be able to identify who is a student versus a teacher versus a staff member in a school, because those network connections are very different and they have implications for how control intervention strategies are implemented. Same thing for places like long-term care facilities. What we know of in those spaces is that it's not everyone mixing together equally, but rather that there is particular network structures or patterns involved in, staff being in connection with with other staff, and then who residents are in contact with. And then there's some other methods that I've been working on to include other age assortative mixing in layers, because one thing that we know is that in a lot of community spaces, it's not just everyone mixing together equally, but rather that you're more likely to interact with people around your own age group, whether that be friends or just people that you're engaging in certain like social activities with. Something that I saw a lot of here in Washington was people still going out to bars, but it's not like they're interacting with all age groups at a bar. They're actually interacting mostly with people close to their own age. And so we want to be able to bring in those kinds of age mixing patterns into our network populations. So very briefly, the methodology is kind of simple, actually. So again, in this work, we're not trying to build up exactly who's in contact with who, and know all of the specific age gaps between different people. Rather, we're just going to use those age mixing matrices to give us that information. And the idea here is essentially, we have a lot of information on the size of different groups by different settings. So I can tell you information about household sizes and school sizes or classroom sizes and workplace sizes. And so I can then, draw, and I also know who is actually present in these different spaces. So I can essentially draw the size of a group and draw the age of a reference individual for those groups. And then from there, I can essentially infer what the rest of the people are, the ages of the people in those groups based on the reference individual. And so really, this is sort of a shortcut, I would say, to generating these networks. It's not perfect, but it gives us a good sense of one, what are the age mixing patterns, and then two, just what are the network structures themselves. So I can say something like, if there is a 30-year-old who's in a household, I can use the column from that age mixing matrix on the bottom right and give us a good sense of the ages of the other household members that they live with. Or if it's a school network, or drawing a reference student, what are the likely ages of the other students that they're in contact with at that school. And so this is what SIMPOPS essentially does, is it tries to generate people in these different social units. First going from the household or wherever people are living layer, and then sampling them in their other social settings. So obviously this uses a lot of data. I'm not really going to go over this, but I just want to give you guys a sense of how much data there is available to you to look at in terms of this kind of work, but also just how much data or where you need to be looking for this type of data. One thing that's really important is that if you want to be modeling very specific kinds of populations, it's kind of useful to actually reach out to the people who have the data. So that's what we did for some of our Seattle-based work, is we reached out to Seattle-King County Public Health to get data from them on long-term care facilities. That's not normally available publicly, but if you want to be doing this kind of work, it's necessary for you to make those connections and try to convince them of, like, look, this is what we're trying to do, and this is how it would benefit you. And so really emphasizing that you need to work with the populations that you're studying, or the people who have those connections, to be able to do this work appropriately. So just want to give you guys a sense of really our first case study with this work. So this is modeling Seattle-King County populations. And so on the left, those are those age mixing matrices that were used to inform the network model. And on the right is the actual results of, you have essentially in these different layers, clusters, I would say, of or social units of people interacting with each other. So in the household layer, you have, given the household sizes, like who's in contact with who, what are the age patterns? And this is, an approximation, so it's not perfect, but it gives us a lot better of a sense of who's in contact with each other than just random mixing, right? And then in the other layers, you can also see, you just have these mixing patterns of, for example, in schools, students mostly in contact with each other, but they also have contact with some of their teachers. Workplaces, you can see the age mixing patterns of the labor force. And then in long-term care facilities, you're seeing a lot more elderly folks, but they're still in contact with some staff members who are much younger than them. So for this work, the reason why we're doing it is because we wanted to be able to help local authorities understand how to control the pandemic in the area, given different scenarios that they could implement, right? So there's a lot of different kinds of intervention strategies that you can use. And we were trying to give them a sense from a quantitative stance of, what's the impact of these kinds of strategies in real world populations. And so this was done using the SynthPop's contact networks in combination with an agent-based model called COVISM that a colleague of mine developed to identify, really what are the conditions necessary to control and mitigate the spread of COVID-19 in the local area. And on the right, you're just seeing some results of this is how well SynthPop's populations can match up to the actual demographic data. And you can see that we do pretty decently. We end up missing we're a little off on some of the age distributions, but we get really, really close in a lot of them of what the age distributions is of the actual populations, and then who's involved in different social settings, like who's enrolled in schools and who's employed. And as I mentioned before, one of the things that we did is that we worked with Seattle-King County Public Health to get information on specific populations that were of interest to them. So for them, they were really interested in understanding how COVID might spread in long-term care facilities. So they shared with us some data, and we also worked with some private long-term care facilities in the area to get a sense of, what are the strategies that these places are implementing. One of the things that they mentioned to us was that back in March, the thing that they did when they first started hearing about infections among their staff and residents was they essentially reduced all contacts for everyone in their facilities to only be, residents staying in their quarters or having as limited contact as possible, and then asking care staff to only be at one facility versus, being employed across facilities. And so with this work, one of the things is that we were able to use that information to really model what the contact structures were looking like in these facilities. So this is on the right is essentially just a picture of what it looks like before any intervention strategies, like asking people to not work at multiple facilities or asking residents to stay in their own rooms. This is essentially what we got information from those long-term care facilities, is that you might have people on average having about 20 contacts in their facility, mixed between residents and staff, and that essentially, there's not a lot of control around who people are in contact with, but that afterwards, all of those connections that you can see between residents in the red and orange colors, those all drop eventually. So I know we're kind of running out of time, and I'm sorry. I talk a lot. I just want to give you very, very quickly an overview picture of what exactly these SynthPops populations look like. So essentially, we're creating populations in the households and long-term care facilities. So this is where people live or work of their care staff. And then they have connections to other layers. So students in the household layer go to school in the school layer. And so the connections between the two different layers represent people who are in both layers. The connections within a layer are actually people in contact with others. And so you can see that really the populations that are created here are essentially multi-layered networks. People living somewhere, going to school somewhere, going to work in other spaces, and then being able to identify who's who, exactly who's who throughout the different layers. So very briefly, as I mentioned, SynPops is the population side of the modeling, but it's not the agent-based model. And so for that, we're using CoViSim, which is, again, another Python model. That's an agent-based model. And we're using this to model how people transition between the different health states of COVID. So it's a standard SEIR model, which means a susceptible, exposed, infectious, and then a recovered model. And we've broken it down actually into quite a number of steps. So you can go from susceptible to exposed, and then from exposed, there are a number of different clinical manifestations of the disease that you can have. You can be asymptomatic, which means you don't present any symptoms, or you can be pre-symptomatic and then transition from being mildly symptomatic, severe, critical, and then from there either recover from the disease or unfortunately die from the disease. The model also incorporates intra-host viral dynamics. So what we know of with COVID is that it's not simply just a matter of are you infectious or not, really. It also matters, what is the viral load that you have and how much can you shed to other people around you. And that has a lot to do with the timing and the state, the health state that you're actually in. So very briefly, some results from our modeling in King County. So with this model, essentially what we've been trying to do is calibrate to local data. And one of the things that we've been able to do is with those long-term care facilities in the model is be able to not only get the cumulative diagnosis, the cumulative deaths, the infections correct, but we're also able to match the age distributions of the data pretty well over time. But it's more than that, right? We don't want to just be able to model the disease progression as it's been happening. What we want to be able to do with agent-based models and network epidemiology is be able to ask questions about what if we have, better conditions, or if we implement interventions like high testing and tracing. And so that's what we're showing here is just in the blue, the status quo. As we know it, these are the interventions that are in place, and this is what the local authorities are able to do. And then in green, what if we are able to implement better strategies of testing? So just testing a lot more and contact tracing a lot better. What is the impact, and can we get those infections to go down, or can we get the number of diagnoses to go down over time? And so something that I wanted to bring up while I have the time is some work that we've been doing in particular to help the local authorities in understanding the reopening conversation. So there's a lot of questions right now about, should we be reopening schools or not? And so what I worked on was these very detailed school contact network structures to help the Seattle public school area ask these questions. So we were asked, hey, if we're able to do things like cohorting or different kinds of scheduling strategies, can that, lead us to better scenarios where we don't have as much risk of reopening schools? And so what we worked on was like, all right, what does it look like in the before times? And that's what you're seeing on the left of this figure is essentially working with the Seattle Public Schools officials and asking them questions of like, what do you think the contact patterns really look like? And what they told us is that, in high schools, it kind of looks all random. Like you can't really control what students are going to be in which classes. It's not really obvious. because students have to walk in hallways and just are engaged in so many different activities, you should just assume that they're all they all can be in contact with each other. So we're sort of just assuming this random networks in high schools. But then what they told us is that, well, it's a lot easier to sort of segregate students in elementary and middle schools. And there you should be thinking that they're mostly just going to be in contact with each other in the same grade. And so that's what we implemented, is just, all right, knowing what we know about the average number of students per grade, or the distribution of students rather per grade per school, and the number of teachers that they're likely to have. What do those network structures look like? And I want to emphasize here that this is not, you might look at this and think like, hey, well, that's not actually what a school looks like, because my classroom when I was a kid looked really different. I wasn't engaged with all the kids in the rest of my grade. The point of clustering students by grade in this kind of a way is to really model the most common risk scenario. We don't want to be, saying things like, well, in the before times, it really was just one class interacting with each other and not interacting with other groups, because we want to be able to include things like the effects of recess or the effects of school lunch breaks and things like that. And then on the right is actually essentially what would happen if they could implement something like classroom cohorting. And again, what they told us was that we can do this for elementary and middle schools, but we can't really do this for high schools. So can you model that for us? And so what we did there is essentially get information from them on what are the classroom sizes, what are the number of teachers that you expect you would be able to designate for each classroom. Do you think that teachers would still have to be in contact with each other somehow, and then therefore connect all the classrooms, and tried to model that for them, and model that under different screening and testing scenarios. And so these are some of the results of our work. So we're using those different network structures and then asking questions about what happens when you implement those different networking, or those different network structures, but also implement different other non-pharmaceutical interventions, like screening students beforehand, before they go to school if they're positive, or implementing things like what's known as an AB schedule. So essentially in that case, you are splitting a school up into two and having one part of the school, one set of students attend school on Mondays and Tuesdays, having a day in between where you clean all the school surfaces as much as possible, and then having a second group of students attend on Thursdays and Fridays. And what I would like for you all to take away from this is that while these different non-pharmaceutical interventions, the cohorting strategies, the screening strategies, they can all be used to reduce the number of infections and the infection rates in different populations in these schools. None of them are perfect, right? So even in the most strictest regimes where you don't have middle schools and high schools in person, but you only have elementary schools, you still have some risk of infection in different populations, in particular for those who are teachers. And so really, we need to have a good understanding of what are the risks involved in these different strategies. And this is what we're trying to do here. Of course, it's not just enough to have a sense of what the cumulative number of infections are. These different strategies have a lot of different costs to them. And so what I'm showing you here is just a comparison of the cumulative infection rate of COVID across these schools versus the average number of school days lost. Because what we know is that asking students to stay home means that they're losing school days in person, and that has a lot to do with how students learn. There are certain age groups that are better at learning from home than others, and so we really needed to be able to present a clear picture to local authorities of just how much cost there was involved in these different strategies. Okay, we're running out of time, so I'm very, very quickly going to tell you that this methodology has been applied to other locations. I have some colleagues that sort of adapted the methodology of these contact networks, inferring contact networks from age mixing patterns in Victoria. I've been working on using this type of modeling for Senegal and modeling a health information campaign there. And then I have some colleagues who are really interested in using this for testing, tracing interventions for polio, because for polio, the thing to understand is that it mostly affects people under the age of 5. And so you really want to have a sense of like, just who are kids interacting with and who are they exposed to, and possibly getting infected with polio from. So up next is, it's not enough to just be able to model how things are currently progressing, but we also want to be understanding how interventions like vaccines could be used and how they would interact with things like human behavior. So very briefly, vaccines have multiple uses. They can be used to prevent infections. So if you get vaccinated, this means you might be able to, not worry about being infected yourself. They can also be used to prevent transmission. So some vaccines are really great at not just, protecting the individual, but also meaning that individual doesn't shed their viral load to others. And what's even better is when a vaccine can also lower the severity of infection. And I think that that's kind of what we're seeing right now with a lot of the COVID vaccines. The news is sort of showing that at least for one of them, I believe, it's not just thought to prevent infection, but it also means that of those that did take the vaccine and get infected, they're really not showing up as severe cases, which is great because severity, unfortunately, leads a lot of people to succumbing from the disease, and that's not what we want, right? So it would be better for anyone that gets infected to at least be a mild case. But there's a lot of questions about, just how does this relate to behavior? So can vaccines lead to a low perception of risk? That's a big question on a lot of people's mind is, if someone gets vaccinated, are they going to change their behavior, right? Vaccination should mean that you maybe can go back to previous behaviors, but what if that interacts, what if the vaccine, can prevent you from getting infected and prevent and mean that the severity is a lot lower, but actually you're still able to infect a lot of other people. We need to be able to understand how those different aspects interact in order to understand what we might see after vaccines start to unroll. And of course, there's also the issue of vaccine hesitancy and misinformation spreading. So are there certain groups of populations out there who are less likely to to accept vaccines? How do we counteract the misinformation that's spreading in those populations, but also how do we counteract vaccine hesitancy because of previous health programs? There are certain groups out there that have been really mistreated by public health authorities in the past, and so have a lot of hesitancy around trusting public health at the moment because of the ways that their communities have been treated before. Again, we're running out of time and I'm so sorry, but future directions for this work, one thing that we're not including in this is anything about vital dynamics. There's very little, about mobility data to model things like traveling between different places in pre-COVID times, because at the moment we're mostly all staying at home. And so what I want to be doing with this work is connecting with other data sets like the Facebook disease prevention data, and also getting a better sense of, how does it look in terms of social clustering by behavior? Are there certain groups that are more risk averse versus risk takers? And do they have certain contact patterns that are going to be relevant for how the disease can spread? Also, university and college settings are super important at the moment because those could be spaces where infection gets out of control. But I think something that I really want you guys to take away from this is, I've been talking a lot about data. I think that anyone that's doing this kind of work needs to understand also just how much data they should be asking for and what the limits of that should look like. You should be asking questions about just how much detail do we need and why. I think there's a little bit too much push on getting all of the possible data out there in the world, and I don't think that that's quite right, because you don't need all of that data to be asking these kinds of questions and to be able to model the risk involved. So you really need to think about what kinds of data you need at minimum. Do I need to know exactly who is in a neighborhood in this particular household and working at this place? No, I need to know a representation of that, some sort of aggregate average, or at least likely pattern, but I don't need to know exactly who. And the reason for that is that I think that we really need to think about how we can protect the privacy of people. One example is the app-based contact tracing. They're doing a lot of work there where they're trying to work to make sure that people are anonymized, but you can still get the relevant disease information from the apps and from people logging or just keeping them on and being able to tell, like, I was in this area, you don't know who I am, but you were also in that area, and so you should be alerted that I'm infected, and you need to take measures to prevent yourself from infecting others. Facebook is doing a lot of this work with their disease prevention maps, where they're actually doing a lot of great thresholding work. So they're not giving you all the details, but they're giving you relevant details. So other future directions for this work is, at the moment, I'm not including anything on covariates like socioeconomic status, race, ethnicity, industry. There's nothing about how people in these different groups cluster into different neighborhoods and communities, but we do need to include that, because as I mentioned earlier, the risk of being exposed to COVID has been shown to have a lot of to just be highly correlated with race and ethnicity. So we know that certain racial groups are being exposed to this disease a lot more than others. And so I would love to be able to include more of these details into the model so that we can actually model that a lot better and be able to, understand how interventions might be able to benefit those groups. Working conditions are also something that we have to think about. So we know is that these outbreaks are taking place in certain working conditions a lot more than others. So meat packing plants are high risk, as well as agricultural settings. And that there are certain groups, there are certain jobs that are higher risk. So frontline jobs, those who are nurses, those who are actually in healthcare, the healthcare industry, they are more at risk than the rest of us if we're staying at home, because they have to deal with those patients. So one of the things that I'm working on is being able to better model who is actually working in these settings and what are the interventions that could be used to prevent transmission amongst them. Do we vaccinate them first, or do we vaccinate other groups? And then just bringing more geographic details into the model. So things like metapopulations, different communities and how they might be interacting. So again, sorry for taking up a lot of time, but just to give you a brief summary of the kinds of work that I'm working on and what network epidemiology can do is really, again, I want to emphasize that different models are really needed for different level questions of complexity. If you want to ask things like, how do we close down schools? Or should we close down schools? Should we reopen them? What schools to reopen, what workplaces to reopen? You need to know the contact patterns that are involved, because without that, you're not really modeling, reality. And so network epidemiology is the right framework to integrate these very rich, detailed contact patterns and then the complex interventions and behaviors. And just, I guess I want to close out on what I'm working on is really trying to be involved in creating the next generation of open source data-driven modeling tools so that we can help with the current pandemic, but also really prepare for future outbreaks, because I think that that's going to be really important for us to understand. And with that, thank you very much. I guess we have a minute for questions, or I'm happy to stay on longer. But I just want to say thank you very much to Alice for inviting me to give this talk and for setting up the Women in Network Science seminar. It's been great to be a part of.
Thank you, Dina, and thank you very much for your talk. I'm happy to stay on for a few minutes as well. and facilitate some questions. So if you have some, raise your hand or type into the chat. There's some mostly comments of how great the talk was in the chat.
I'm trying to
Sneha,
see it. I'm sorry, like I don't know where it is anymore. Here we go. Okay.
So I had a very lame and technical question that I'm just going to skip now. I'm going to move on straight to Sneha's question, which was, if I understand it correctly, the networks you create have different layers corresponding to different criterion, such as household, etc. So are there any characterizers specific to multi-layer networks that you use? The measures related to supralaplacian matrix, for example?
No, and I'd love to learn more about that because I have no idea what that is. So we should talk. No, not really. I mean, one thing that we were trying to do with the multi-layered approach is at least be able to model things realistically in terms of like, you know, siblings working, going to school at the same schools, right? That I think is probably the most related, but I'm not really sure what else. Sorry. Other questions?
We have one from Nick.
Thanks for a great talk, and thanks for all that you're doing. I appreciate it. A question that I had was just to make sure I understand the process. So your partners basically tell you the situations that you should investigate, kind of? Like you aren't examining like all the state space of interventions, or, and then how do you determine what's, like they determine what's the one they want, right?
Yeah.
Like,
yeah.
can you explain more of that?
Sure. So it's kind of more of a back and forth. They'll give us an idea of what they're interested in understanding, and we'll try to take that and then explore the state space around there. So it's not just one curve that we're interested in, like just one scenario specifically about you know, reopening schools or things like that. We do some sensitivity analysis around what they suggest. But the reason why we go with their suggestions is because that's what they think is feasible, right? So I don't think that it really makes sense for infectious disease modelers to necessarily be modeling, you know, best case scenarios if the people on the ground think that that's not something that they can actually feasibly implement. Does that make sense? Like if
Yeah, totally.
One of the things that with the schoolwork, for example, was like, it would be a lot better if you could really keep students separated and segregated from each other. And one thing is like, you know, just making sure that their teachers are not in contact with each other so that you don't have a completely connected or a connected school network. But our partners told us that that was not feasible, that there was likely to be some interaction between staff and teachers in schools, and that you couldn't really keep them disconnected in that way. So we have to be able to take that into account. We need to really understand like what is something that they can do and what's something that they can't do, because it doesn't make sense for us to be modeling a best case scenario that they're just not able to implement. Of
Cool.
course,
Thank
the
you.
other thing is that you do want to try to push them towards scenarios that would be better, right?
Mm-hmm.
Other questions?
I'll just insert my question here, which is that, so in my head, I'm already kind of hoping for 2021 and COVID-19 to be a thing of the past. We'll see how realistic that is. Probably you'll know before I know. But say, if we have to think about what comes after and whether at some point there's going to be a new next pandemic, what would you say are kind of the things that the scientific community can contribute in terms of being better prepared next time?
So I've talked about this with some people that I work with, and I think one of the things that I'd like to see, and that a lot of us would like to see, is better, like just having these tools available. So Like Covisim and Simplops were sort of just created during the pandemic as things were progressing along and sort of very much in response to the pandemic. I would rather us have these well thought out tools where we've like, really spec'd out all the details well before in advance. Like just not having to develop them on the fly in a very not hurried sense, but just sort of in a just more in a responsive state. I think that we need to be emphasizing like, let's prepare beforehand and have these tools available, but also what are the data that we need? And do we have robust systems that can collect these data across different parts of the country or the world? And like, just how much data do we need to be collecting, right? Like, I think I kind of mentioned this with the data privacy issues, is like, how much data do we need? And I don't think that that's fully understood yet. Like, do we need to have, do I need to know exactly who is moving around and in contact in different spaces? Maybe. I would like us to be thinking more along the lines of just what those thresholds of data should be. And there's probably a lot of other questions that a lot of other people are thinking about, and my brain is sort of not able to think of them right now. But well, okay, so another thing is also like the vaccine and behavior stuff, right? How do we roll out vaccines when you have limited resources? That's going to, that right now is like a really big question. And then for future pandemics, like what do we do again when there's no vaccine immediately? Like, what are the best strategies? What did we learn from? I'd like us to be taking account of what we've seen from this pandemic, and not just from like the mechanistic quantitative modeling perspective, but also in terms of how much impact has this had on people around the world in terms of economics, in terms of life quality? Like, have we left other diseases unchecked? One thing is that with all the focus on COVID, it means that strategies or programs that have been put in place to reduce transmission of other diseases like polio or like measles in certain places around the world have kind of been stopped. And that means that you're seeing a lot more infections from those diseases. And I think that we need to be thinking about not just COVID or a particular pandemic outbreak, but how do those diseases interact with the transmission of other diseases? Any other questions?
So since we're already a bit over time, I might close it here. Thank you very much, Dina, for this very interesting talk, the great Q&A. I am absolutely fascinated by this. This is closer to reality than most of the network science that I interact with in this venue and others. And yeah, as Nick said, I'm really impressed. Thanks for the work that you're doing, and thanks for the talk today, and good luck with the whatever's next for you.
Thank you very much. Yeah, it was a pleasure to be involved in this. And of course, again, like this isn't just my work, it's the work of a lot of people. And I'm very, very fortunate to be able to contribute what I can.
Thanks to all of you. And so this was the last Women in Network seminar for the year. I'll be back in touch over the email list. Talks planned for next year. So hope to see you all then. Bye.